Okay, great. Well, welcome everybody to the CGHE, the Center for Global Health Equity Data Collaborative's second workshop. We commenced the workshop series just a couple of weeks ago, and we're thrilled to have here today with us Abram Wagner, an assistant professor in the School of Public Health at University of Michigan. And Abram not only is an assistant professor, but also leads the vaccine equity community of practice at CGHE and received a CGHE award from our Vaccine Equity Ideas Lab. So we are thrilled to have him here today to talk about an introduction to DHS data, and we will learn much more about that in just a few moments. For those who I don't know, my name is Josh Ehrlich, and I'm one of the associate directors of the Center for Global Health Equity, specifically of the Data Collaborative, and associate professor in the medical school and at the Institute for Social Research. So I will just say a few words about the Data Collaborative for those who are less familiar with us, and then we'll get started on Abram's talk, which I'm excited to hear. So we can advance the slides. So for those who are not aware, the mission of the Data Collaborative is to convene, consult, and collaborate in innovative ways, both at University of Michigan, but also with partners in the United States and around the globe to utilize data for better health. The enabling functions of the Data Collaborative are organized around three core pillars. Next slide. And these pillars map to number one in the upper right there to data discovery and data harmonization. At the bottom, data analysis and doing data analysis that's fair and equitable. And then up in the upper left-hand corner, data dissemination. So this involves transforming data into visualizations, other platforms, methods, harmonizing data, and making data widely available to the research community. One example of that, next slide, is the data archive that we're currently building. You can access this; it's available online, but it's growing all the time, and it's an archive in collaboration with ICPSR, the Institute for Social Research, where we're doing all that we can to make data more available to the global health research community through this open access archive. And next slide. And then finally, one other aspect of the Data Collaborative that I wanted to draw all of your attention to is yet another new initiative, which is our pilot funding through the collaborative. We're looking for action-oriented projects that will create something bigger than the project itself. That is something like a tool, a model, a methodology, an app perhaps, something that will allow us to advance the mission of acquiring and applying data, largely from low middle income countries. We're also interested in new open source data resources. And if you have any questions as to what that might entail, what that might look like, Christina Rice, who's with us here today and is running the slides, is best contact. Her email is there. Applications will be due the 27th of February, and the grants are for up to $25,000 per project. More information available on the CGHE site. So I hope many of you will consider applying. And with that, we'll move into to Abram's talk.
Well, thank you very much for inviting me to talk today about this. I've used the Demographic and Health Survey, or DHS, program data in much of my own research, and I am sure that many of you who are in the audience have also used it. But I wanted to give a brief overview of what it is in case you do not know what it is. I will talk about how you can use it, what the history of DHS is, maybe some concerns about its future. And then I'll give an example from my own research of how I used it and what were some pitfalls. So DHS, at its basis, it is a harmonized survey that is collected at regular intervals in many low and middle income countries. And this is just an example of their questionnaire, which they will have for their site visits to the households. So who is in the DHS? There's different layers to the DHS, there is a household questionnaire where they ask questions of everyone who is in a household, and that's given to the head of household. Uh, Probably the largest and most extensive section is the women's questionnaire, where women 15 to 49 are asked additional questions. In some countries, these are only women who are married, but in other countries, it's all women. Um, then there are separate questions which are asked to a man in the household. And then through the women's question, there are more questions which are asked about children who are under 5. So there was a literature review from about 12 years ago. So this is already probably way out of date, but I think the relative numbers and the proportions probably are similar to what you'd find today. And this was just looking at all studies which have used DHS data, what has been the theme or what has been the topic. And the plurality have been those which are about child health and mortality, followed by fertility and family planning. But there are DHS can be used to study a number of other things, including nutrition, maternal mortality, gender empowerment and gender violence and other gender issues, HIV/AIDS and other STIs, issues with poverty and wealth. And then in some situations, there's modules on malaria or water and sanitation. So it really is an extensive study. Where is DHS? DHS operates, like I said, in many different low and middle income countries. Often these are places where the U.S. Agency for International Development, or USAID, has operated in the past. So this is just a map of the world, color coded by how many surveys have been conducted in it. And so many different locations in Central and South America, in Sub-Saharan Africa, a few countries in Middle East, North Africa, and South Asia, Southeast Asia. These are the places where there are a lot of DHS surveys which are being conducted. So why does DHS matter? This has been hugely important for demographic and health monitoring throughout the world. It is a high quality data set where we can get nationally representative data, and we can also have comparisons across countries and within countries for different regions or states or provinces, things like that. It's used by many researchers, people like myself, but also by people in ministries of health, by international agencies, and the WHO also will use it for various indicators, including for the Sustainable Development Goals. So the background to why DHS came into fruition was a lack of vital registry data in much of the world. So this is actually data from 2019. So numbers are probably better now than they were in the 80s when the DHS started. But vital registry, that's talking about things like birth certificates, death certificates, along with marriage and divorces. So that is an important civic function. And so here in the United States, we have pretty good coverage of vital registration. So we have birth certificates for pretty much everyone. We have death certificates, which list the cause of death for most almost everyone. But that isn't the case through much of the world. And in this map, you can see that even in some places in Central America, through much of Sub-Saharan Africa and South and Southeast Asia, there is a lack of comprehensive coverage of vital statistics. What that means is that we don't have like a really good idea of why people are dying and how many births there are in different locations. And this spurned the development of the DHS in the 80s and its precursors, which was at its basis, can we study who's getting born in a certain country And can we collect some limited information on morbidity, so what kind of sicknesses there are, and and the number of deaths. So DHS sort of was I wouldn't say a replacement for vital statistics, but it was a supplement in many areas where there wasn't comprehensive vital statistics. Of course, DHS is not a universal program, but it is a cluster multi-stage observational study. So we're not having 100% coverage of the population, but we're doing a study of a snapshot of people within that country. So the first DHS was organized in the early 80s and was implemented in 1985, and there's been substantial changes since then. So we've added more questions, so more things on anthropometry or kind of measurements of children. At first, it was just a women's survey, but then added more for men. Um, Over time, modules have been added uh, on things like domestic violence, female genital cutting, anemia and hemoglobin testing, asthma, tuberculosis, lead, syphilis. Some of these have kind of been a one and done thing where there's been a module for a limited period of time and that's gone away, but some of those have been incorporated in iterations in future iterations, making the survey more comprehensive over time. So yeah, so this is just a chart showing that over the first 25 years, there's been an increase in the diversity of questions which have been asked in DHS. And the different iterations of DHS are called phases. So we are already at phase 8, but there, have been 7 prior phases of the DHS. Now, not every country will have a um, a survey for each phase. And actually, I believe that there are some countries which may have had multiple surveys within one phase. So the phases don't necessarily correspond to how many surveys are given in an individual country, but this is just a way of thinking about what are the standard questions which are asked of everyone at a certain time point. And then um, countries might elect to have additional add-on modules, or there could be slight differences across countries in some additional questions that they might want to ask. So we are already in phase 8 of the DHS, and there was a concerted effort at the time point of DHS 8 being rolled out to gain feedback from the scientific and the public health community. So they opened a portal for people to submit additional questions, which could be added in, and researchers were able to provide an argument for why certain questions should be added in. So about 900 questions were asked to be added in. They ended up adding in 180 of those, and then ended up deleting 120. With any observational study, we need to be really careful about how long the survey is and what the burden is. And DHS is pretty um, long as is. So with any iteration, we're thinking about adding in new questions and deleting some additional questions. So if we're thinking about the new things in DHSA, just in case you're kind of curious about what are some of the forefronts of the survey, they have now more detailed pregnancy history. They ask questions about age at menarche for women, along with breast and cervical cancer screening. There's more comprehensive information about marriage registration. I think in some of the previous iterations of the DHS, they more so were asking about like cohabitating um, history instead of marriage specifically. I think they're now putting self-reported HIV status as a specific question in, and a variety of other questions like use of mosquito nets, iron supplements, and some more nutrition-based questions. So this isn't comprehensive, but just an idea of there's churn over time in the types of questions which are asked in DHS. So if an individual country decides, oh, we're going to do DHS, we're going to implement a DHS survey, how long does that take? And we're thinking about um, 2 years, maybe even a bit longer than that. There are several months where the survey needs to be potentially localized to a context. That could include translation and back translations, if there is a local language which hasn't already been included in the study. There are some tests of the sample design and some pre-tests of the survey just to make sure that it can be implemented correctly. And then trained enumerators need to go into the community and do household listings within different clusters. So this is a cluster-based survey. So we are going to be having a primary sampling unit or a PSU across the country. In most countries, we will also stratify by urban and rural areas. So we have clusters in urban areas in many of the provinces, clusters in rural areas. And then within those clusters, you need to do a household listing uh, of, and then eventually be selecting households. You need to be training the field staff, and then you do data collection. And concurrent with data collection, there will be cleaning of the data and editing of it, various tabulations. There might be some preliminary reports already by the year two, but it takes some time to clean up the data, to present some workshops, to edit the final report, and then to release the data. And part of the data release is historically, at least there's been various data use workshops and different ways that the program tries to promote further analysis. Of course, with limited funding, some of this may or may not be happening in the future. So historically, DHS was funded through USAID, and the reason why is because USAID was operating in many countries. It was sort of a goal of the United States to promote health of people worldwide and to invest in these international development projects. But um, there was a need to collect data on the ground. Now, many of the early international development projects that the US was focused on were related to family planning. And the DHS was born out of previous fertility surveys, which had been conducted in many different countries, but DHS was much more comprehensive, was much more robust, and included additional questions. But at its core, there was a focus on reproduction and family planning that was a big part of this. And that was just because I think people wanted to be able to do some sort of program evaluation of USAID projects, potentially using a more robust data source. So DHS has been implemented through ICF International, which is a private company, but there has been some changes in the past year. So as we probably all know, in February, President Trump cut funding for USAID, and that also included the DHS programs. So there was not a clear understanding of what that meant for the program, especially since ICF International sort of held all the data in an online archive, but wasn't really getting money anymore to fund that. So for a while, it was allowing people who were already registered to access the data, but it wasn't doing any additional registrations. So within the past month or so, the Gates Foundation did mention that it would fund the website and the data archive for 3 years. There might also be some additional funds to push forward the cleaning and release of data in those countries where there already has been the data that has been collected. And that's a particularly concerned because there's more than a few countries where the data have already been collected, but it's just not in a place to be publicly distributed. Um, but it would be an unfortunate waste if we were unable to get to that. So I think they're still figuring things out. And maybe in the Q&A period, if other people have more information about what's happening with those data sets, I would love to hear that. Okay, so there are data sets which are available and they're freely available for everyone. But DHS also puts out a model data set. And for people who are interested in this, I do recommend actually first downloading a model data set and playing around with it before requesting um, a full scope, like the actual data. So model, what do we mean by model data set? A model data set is a fake data set that DHS put together, which sort of models some of the relationships and has many of the questions, at least from the DHS 6 module. And it's a great way to become familiar with the DHS data and to have an idea of what you can analyze and what you can eventually access. Another hot tip that I have is to use the .frq file, which comes along with the data. There is a .frq file for the model. You can look at that. So I will just pull up a real .frq file, and you can. I think DHS just made up this .frq suffix. But you just can open this in any notepad or whatever that you have. Um, and this is one from the Indonesia 2017 DHS dataset. And basically, this shows for every variable in the dataset, how many people responded to every question and different responses. Now, I teach a class and students use DHS datasets, and I think they open up the .frq file and they find that there are just these pages and pages of random things which don't matter at all, quote unquote, don't matter at all. But this is just like the background survey information. You really have to um, go down quite a bit before you start getting into some more of the interesting questions, where we start age, where we could be asking about, where people are living, and, then we start getting into, yeah, are people using the internet? Do they have a bank? Um, and it's important to look at these early on because DHS has somewhat odd skip patterns, or there could be a lot of missingness in some of your questions. So, for instance, for this question, do you have an account in a bank or another financial institution? We have no's and yeses. We only have 88 missing. So, I think for a survey with almost 18,000 people, that's a pretty good number. But there's this question. Do you use a mobile telephone for financial transactions? NA, so not apply, or basically missing. Everyone's missing. So clearly, this was just a question that was not asked as part of the Indonesia 2017 dataset. If this was a really important question for your own research, you just can't use this dataset for it. So even if in the questionnaires that you find online, you see this as a question, if you look in the .frq file, you might just find out that you don't really have access to this question. There's not variation in this. This is just the unweighted counts and the unweighted frequencies, but I think it's incredibly useful. Um, since I just have it up here, I'll also mention there's not comprehensive income information that's collected as part of DHS, but they do have a wealth index, which is pretty much principal components analysis of various uh, possession of various household objects and kind of what your home looks like. But they categorize people into 5 different like quintiles of how wealthy they are. Okay, so with the .frq file with your system, in PCs, you can just search for something. So if I was interested in a BCG vaccine, but I don't know what this is coded for, I can search for BCG, and then I get this question, and this is H2 in the data set. And this shows that for H2, there are five potential options: 0, 1, 2, 3, and 8, meaning no, vaccination date on car, reported by mother, vaccination marked on card, and don't know. So these are, so again, .frq is, I believe, the best way for searching for an individual data set. Who's who's in the data set, how many people are in the data set, and what kind of variation is there across the different questions. So I think when you're first getting familiar with DHS, just scrolling through this, again, you have to kind of um, the first like third of this is just background uh, survey information. So you really have to scroll until you get to the questions which are asked of the individual. Okay, so say you're interested in DHS, you've kind of played around with the model data set. How do you get access to the data set? You can register at dhsprogram.com, at least you can as of a month ago. A lot of these slides are from, or these images are from Brad Carlson, so just wanted to let you know that and attribute this to him. So you have to create a new project. um, you have to provide a description of the study, and they really want you to be doing a research-based study. They don't want um, you just to be using DHS to learn more about statistics or to test out doing various, I don't know, various types of mathematical or statistical models that aren't going to be published. I think they are trying to push you to actually be doing a research study. Um, And but like once you register for this once, you kind of have free access to download whatever data sets you want. You download your data sets. If you do want GPS data sets, you need to provide some additional information about why you need the GPS, because that's an additional level of sensitivity. And then you can submit your request online, and I think we did this last month, and within a couple days, our project was approved. So things are going pretty fast right now. There's different file names for DHS, and this is maybe where it gets a bit complicated. We'll go through this in a moment, but basically, a DHS dataset will have the country code. So, if it's India, it'll be IN. If it's Indonesia, it'll be ID. Kenya, KE, things like that. Dataset type, I'll go over this in the next slide to explain what this means. There's a version, and this refers to the phase of DHS, so 1 through 8, and then there's a different release version. And then, how are you getting the data set? Is this SPSS? Is this data? Is this SAS? So, for instance, for Kenya, for its DHS4 data set, these are all of the data sets that are available. There's different units of analysis, and then you can download them in different softwares. And uh, basically, this table is just showing how those contribute to the file name. So let's go over this unit of analysis. There is the household recode, or the HR. That's household level information. So the enumerator selects your household, goes to your household, and asks some basic questions of you. Um, and everyone who's been residing in that household, I believe the previous night. So there's only basic demographic information on the household recode level, but this is everyone who's in the houses which were selected as part of the data set. Um, Yeah, I think actually most of that would be in the person recode. I'm sorry. The household recode has less information, and that's just household level data. The person recode will have information of everyone who's resided in that house in the previous night. Then for the men who are in the study, who are 15 to 49, they are asked some separate questions, and that is in the male recode data set. And then there is the women's data set, which they call the individual recoder IR data set. And this is women who are 15 to 49 who are in the study. And again, some countries, they also have to be married. But so women 15 to 49, maybe women are have to be married to be included in this, but they are asked additional questions about themselves. Now, women are also asked about children that they have. Um, and these children have to be 0 to 59, and that will show up in the children's recode data set. Now, if there is another child who resides in the household but who is not an offspring of the woman, that person would not be included in the children's recode data set. They would be included in the person recode, but there's much more limited information about them in that data set. The child also has to be 0 to 59 months. So if a child's like 8 years old, 12 years old, they're not going to show up in this data set. There's also a births recode data set. A births recode is it includes every child that the woman has had. Um, so up to 20. And I don't think there's many women who have more than 20 children. So this could include information from kids who are 12 years old, 15 years old. Um, and these are births. It will ask if the child is still alive, but there has to have been a birth. And yeah, again, this is only for offspring of the woman who previously was interviewed. So when you look at the DHS data sets, there's just the unit of analysis or the row in the data set is different. So the household recode will be sort of the shortest data set because there's only, it's one row per household. For the person recode, that'll have a lot because that's like everyone who's within the household. Um, Men and women, that'll be probably relatively the same. Children's recode will have more, and then the birth recode it could have even more, assuming that there's more children who are over 5 years of age. So these the questions asked for each of these are also a bit different, and that's why it's always best to like go back to your .frq file. This is for the Indonesia. This is for the children's recode, and you can tell by KR, and it's in DHS 7. So that's what we know by this. And so the questions which are asked for in the birth recode, there's a different set of questions versus in the children's recode, and so on. Uh, that is the complication of DHS. When you analyze DHS, you should also take into account different survey procedures, including cluster, strata, and weights. Clusters, another name for them, it would be primary sampling units. These are the villages, the neighborhoods, the blocks, where households are selected from. Again, this is not a simple random sample from the entire population. So in India, they're not just doing a simple random sample of everyone. They first select different clusters, and then they will choose households within that cluster. Now, the benefit of using clusters is it makes the fieldwork feasible and makes it so this is something that is, economically we can deal with, but it does decrease precision. So if you analyze the data incorrectly by not accounting for clusters, you'll have more precise confidence intervals. You'll have lower p-values. But once you account for clusters, your p-values will go up, your confidence intervals will widen. Um, and that's just because you're realistically dealing with the sampling of the study. The cluster for most analyses would be something like B021. Strata you could think of a number of different ways. In DHS, this is basically just urban versus rural areas in different states or provinces. Um, the difference between strata and clusters is strata kind of cuts across different clusters. Um, and strata can be a variable which is highly related to different health or demographic outcomes. So we would think like urban versus rural is probably very strongly linked to things like fertility, infant mortality, vaccination, malaria, HIV status, a variety of things. So strata, accounting for strata actually makes your study more efficient. So your p-values will go slightly down, your confidence intervals will decrease in size if you account for strata. Probably not enough to make up for the clustering, but if you're dealing with clustering, you might as well also deal with stratification. Then we also need to use weights. Because we're clustering people, we might be oversampling urban versus rural areas depending on the country. Um, we have an unequal probability of selection into the study, and there also can be non-response of various households. So we want to account for that through weights. And by counting through weights, you make sure that your sample results are nationally representative. And the value for weights is V005. According to DHS, you should be dividing this by a million. I think that's more so an issue with older uh, statistical programs. I don't think this matters so much anymore to divide this, but just putting that out there. I'm not going to go through the code too much, but there are very easy ways in things like R, Stata, and SAS to deal with survey procedures. So in R, you just load up a survey package and you specify your survey design by specifying the cluster under IDs, you specify the strata, you specify the weights. And then there's a whole series of SVY-based procedures. So if you're running a logistic regression, you use SVY GLM. You have your outcome, your exposure. You could add any confounders you want, but then you just specify what the design is from this previous function. For Stata, similarly, you would just load up this SVY set and you have your variables for clustering weights and strata that you add in. And then I think Stata is pretty simple in just adding like SVY in front of a number of different functions. And that's pretty easy. SAS also, it's pretty easy just through a variety of different procedures. There's like survey logistic for binary outcomes, there's survey reg for continuous outcomes, there's like a frequency tables and a number of different things. You'll just specify the strata cluster and weights. And then you can use, add in whatever flourishes that you want to that. Okay, so I am going to go into an example of how I have used DHS in the past. This is a project that I worked on with some colleagues from Indonesia about 4 or 5 years ago, and it's published in the American Journal of Preventive Medicine, and it's called Religion and Measles Vaccination in Indonesia, 1991 to 2017. So, rationale behind the study. India is a majority Muslim country. In the mid 2010s, there were a series of fatwas and rulings that mentioned that measles containing vaccines contained or at least were processed with haram ingredients. I think the big concern was sort of a pork gelatin being used in the vaccine manufacturing process. So they raised concerns about these. A lot of back and forth about sort of the theological jurisprudence of what this meant. There is, concerns about there's the concern about the vaccine being haram or not, but then there's also other issues of like, is it an emergency situation to get vaccinated or not? So there's sort of like the theological law and people going back and forth. But overall, the national Muslim organizations were promoting vaccines, or saying that this is a situation where you should still get vaccines. But then, as you probably have all noticed based on current events in the United States, it's not so much whether there's like a specific law or like a specific ruling that comes out, but there's sort of like vibes of being anti-vaccine and or not liking vaccines. So we just wanted to know, um, were these vibes different for versus non-Muslim Indonesians, or were there different trends in vaccination coverage over time? So Indonesia is one of the countries for DHS where there's a number of different data sets. So I was able to download, I believe, DHS from and a child's recode from DHS 1, 2, 3, 4, 5, 6, 7. So a lot of different data sets. Um, I was able to include as part of this from 1991 to 2017. And so, you can compute all sorts of fancy things with DHS. So across time, the proportion who are Muslim is relatively constant. Um, Vaccination coverage in general was increasing for things like measles and for diphtheria, tetanus, pertussis. Um, the between 2012 and 2017, which is like around the time that these like fatwas were being introduced, there was maybe like a bit of a stalling in the increase in measles vaccination coverage, especially compared to other vaccines. But what this was just kind of what we saw overall. We also did split this up by religion, the religion of the mother. So we looked at what was the vaccination coverage over time. In general, there was like pretty similar vaccination rates, and this is for measles vaccination. Um, there's sort of like an increase, at least in the 90s, but then sort of a stagnation in increasing. Maybe coverage in Muslim families is a bit lower, but not super, super, super lower. Um, Maybe there is a widening in the 2010s between Muslim and non-Muslim populations in their vaccination coverage. So we did some additional fancy tests and we found some of this trend was significant. But we also just um, graphed this. So this is just a choropleth map looking at measles vaccination coverage across different provinces in Indonesia. And what we saw is that vaccination coverage was the lowest in Aceh, which is this area, it's the westernmost province in Indonesia. And this is also where my collaborator on this project was from. And because we saw that this was really low and this was sort of a geographical thing, we decided to do an additional study here. And that is our big study funded through the Center for Global Health Equity is looking at can we use religious leaders or community health workers to try to improve vaccination coverage in this province. So I think a huge motivation of that study, which ended up getting funded, was getting some empirical data from DHS to analyze this a bit more. Now, to get to more of a concluding portion of this talk, I think there are some pitfalls to using DHS data. Um, in particular, there's a lot of variables. Like if you look through the .frq files, there's so many different things that you could end up analyzing, and that's great. But that also means that as you are doing an analysis, if you don't have a theoretical underpinning for your research, you might just be including a lot of variables in your analysis. You might end up with like a table one that is like 3 or 4 pages long. You could be starting to run statistical analyses or computing chi-square tests where you're relating multiple variables together, which maybe don't need to be related together, or maybe there's just like a spurious association. And there has been concern in the social sciences about this idea of like how reproducible is research if we're just taking whatever data set that we have, if we're analyzing a bunch of associations and then just presenting the significant ones. Um, so DHS has been, I mean, many published studies of DHS, but as I'm sure you all know, to get things published, generally you want to show statistically significant results. And I think for every DHS study which shows a significant result between variable X and variable Y, there are probably a few out there which have not shown a statistical association, but just haven't been able to be published because they didn't find that association there. So that's not so much a problem with DHS itself, but just sort of as a scientific enterprise, we can do a lot of analyses, and our statistical tests are dependent on the sample size. Like the significance of statistical tests is dependent on sample size, and DHS is generally a huge data set. There's thousands of people in any individual DHS data set, so you can often find statistically significant things. But just because something's statistically significant does not mean that it's important. And just because something's important does not mean that it will be statistically significant. So that's just sort of a higher level issue with this. But yeah, overall, I think this is great. This is, um, I don't know, probably more than a dozen DHS analyses and got them published over the years. And many of the students in the global health epidemiology program, they'll be using the DHS data set as well. So I think it's a really interesting tool. So to sum up, why is DHS important? It's I would consider it a global public good. It's open access. It's nationally or open access with reasonable request for data. This is nationally representative data in many different countries, and it's in many of those locations. There's a series of cross-sectional studies that you have access to. One thing I will mention is that there are other studies out there. Like there's the MIX, the multiple indicator cluster study, which is put on by a UN organization. There's other things. And given that DHS funding is a bit precarious right now, does the Gates Foundation just completely take it over? Is it handed over to the UN? Do we just wait out until USAID funding comes back online, if that ever happens? There's many questions about the future of DHS. But so we can use other surveys, but like there's really a hole if DHS goes away. This is standardized questionnaires. There's a lot of harmonization and a lot of thought that takes place into developing these surveys. And there is a tight connection with policy. Many of the questions are asked in a certain way to inform health strategies by ministries of health, by the WHO, by UNICEF. And like I said previously, a lot of these are linked tightly with the Sustainable Development Goals. Many different people have published based on this, so there's a strong research foundation. And in the past, the DHS was very good about trying to get people from low and middle income countries to also be leaders in analyses. So it isn't just people at the University of Michigan doing analyses. It's what can people within these countries themselves actually be doing. And then there is various capacity building that can be done. Like in the DHS process, you're training people, you're training organizations to run studies, to do high quality surveys, to develop questionnaires. And those are the types of things which can be broadly applied to a variety of different settings. Okay, with that, I will stop talking. Love to hear any questions that people might have, but also feel free to reach out in the future if you have a question about DHS or if you have a research idea with it. Thanks.
Thank you so much for that, Abram. That was a really really informative whirlwind through what I know is a massive topic and tough to compress into 45 minutes. So great job, great job. I certainly really enjoyed that. Um, I put into the chat here if anybody has questions, feel free to place them into the chat or into the question and answer section of Zoom, and we'll field those. But maybe while people are getting their thoughts together, I could start us off with a question or two. With the you mentioned and spent a little bit of time discussing the shuttering of USAID. But with the shuttering of USAID, how fast do you anticipate that the DHS data, despite being continually hosted, at least for the time being, by Gates, how fast do you anticipate that those data become sort of less timely, less indicative of the situation on the ground? And are there, I guess the corollary to that is knowing that there is some time in which they become less timely. Are there countries that are finding their own way towards funding DHS data collection independent of USAID?
Yeah, I mean, realistically, the data probably becomes out of date pretty quickly. There's always like interesting things you can do. Maybe you find out, oh, there's a natural disaster that happened in Kenya in 2000. I want to see using the data from 1995 and the data from 2005, like, was there a change? I think that could be a research question that like exists across time. But if you're trying to think through, oh, I want to see, what is the fertility rate in a country. Yeah, you can't look at data from like 5 years ago. Those are rapidly changing things. So a lot of DHS data sets have been uh, put together in a way that oftentimes they're kind of done every 5 or so years in many of these different countries. And I think that kind of reflects patterns of demographic changes or when there be wide scale changes to health or uh, other policies which could impact some of these indicators. So yeah, I do think that this becoming out of date is a concern. I'm also very concerned with the data that have been collected but just haven't been released because they haven't been adequately cleaned yet. Um, Especially since like we're talking about data from 2022 through 2024. So that's is pretty recent that could be used, and people on the ground spent a lot of time on this, and I think it's sort of ethically a very sad situation to be in to spend so much time doing research studies and then not release the data. Certainly, countries could switch to doing other things. That there has been an increase in coverage of vital records. So things like births and deaths are more commonly registered in sort of civil systems now than they were in the 1980s when DHS first started. There certainly are other wide-scale surveys, and the Gates Foundation has all these verbal autopsy things for looking at deaths. So those are other ways of kind of analyzing things. It's hard to think of another kind of set of surveys like DHS, which is used so comprehensively throughout the world. Um, I believe probably the one closest would be, yeah, the multiple indicator cluster survey or mix, which has been used in more countries, in some other countries than DHS, just because DHS is more of a focus of USAID and mix was funded through another way. And there has been some harmonization of those two different surveys over time to ensure more comparability. Um, so I think that could potentially be something, but it's hard to think that any one thing could kind of fill the hole left behind by DHS.
Yeah, fair enough. No, that's certainly a concerning situation. Thank you. We have a question from Preet Rana, who you may know. She's a global health librarian at Taubman. Preet asks, if some countries find their way to funding their DHS surveys, is there a concern for expanding inequities further? For example, countries that are able to fund versus not able to fund.
Yeah, I mean and I'm sure Preet would be able to speak to this as well. One of the ways to not have an inequity or not have an inequality is to just like not study it. So you can have a lot of problems go away if you don't shine a light on them. So I would agree that there are some countries which would be able to kind of put together DHS-like systems, probably not making it open access. But yes, realistically, I think that absolutely could happen. And then, so I I agree with that concern, and I would echo it that that is one of the problems with DHS going away the the lack of data, the lack of disaggregated data from many places, and just like not being able to understand inequalities which are occurring.
Thanks for that perspective. Another question from Jorge Canari. He asks, he says first, thanks for the presentation, and asks if we want to perform a multi-year panel analysis, can we adjust the sampling design to make such estimates? Or is it only possible to make the estimates by considering the sampling design adjustment for each year separately?
Yeah, so this is a really great question. One thing I didn't mention is that the DHS program has a relatively active forum where you can pose questions like this. The problem is that you'll get like three different answers for it. But it's great that there's such a large community of people who are using DHS and who have been really interested in thinking through things like how do you combine data across different samples. So I worked in two different types of studies. One where like the Indonesia study I showed you, where we looked across time um, at within one country. And then you can also look at kind of a similar time point um, across countries. Now, there's different ways of dealing with the sampling. For my Indonesia study, I think I pretty much computed statistics separately for each year, so that really wasn't a big issue. I didn't really need to combine across years. Um, But if you combine across years or if you combine across countries, there's sort of two philosophies. One would be, do you try to adjust the weights based on the size of the birth cohort or like whatever your population of interest is? I predominantly deal with children, so you could adjust it to the, size that the children's population. If you're dealing with like women 15 to 49, you could adjust based on projected sizes of those populations. Um, the problem is with that is you can have some countries like drown out other countries. Like if you had Nigeria and Ghana in your analysis, there's so many more people in Nigeria. So like any trend seen in Nigeria will drown out anything that you see in Ghana. Um, but yeah, so my recommendation, which I'm sure some statisticians and methodologists might have an issue with, but like hopefully some would also agree with me, is I would probably just I would consider like what is your main research interest if you're just trying to look at are there if changes over time in a place, I might just adjust the weights to be the same for each time point. Um, Unless you have a need for making assumptions about like the birth cohort size being pivotal to your research question. And it'd be hard for me to imagine how that would be the case, but it could be. Um, so yeah, which is all to say, like, yes, I think you can account for the sample design across time and across countries. It's just thinking carefully about what your research question is.
Great. Any other questions? Any last questions? We're just coming up on time. Could squeeze in one more if need be. Anybody's got a burning question? Otherwise, I will turn it over to Christina for some closing words. Thank you again, Abram. We're very grateful for your time and for you sharing your insights on this important data source.
Thank you.
I just have a couple of updates from the center. Let me share my slides here. So the first is we have a community gathering next Tuesday that starts at 3:30. You can register for that on our website. And next is just a quick reminder. We have several funding opportunities available to U of M faculty. Josh mentioned our new pilot funding related specifically to the Data Collaborative, but we also have seed and impact accelerator grants. The seed grant deadline is October 30th, and the impact accelerator grants will have another deadline in the spring. And then last but not least, we also have an Impact Scholar program that is for postdoc scholars that are fully funded through CGHE. They prepare early career scholars for work in global health research and program development, and that deadline is November 7th. So with that, I will just second Josh's thank you all for joining us, and we hope you'll attend our next workshop. So thanks.
Have a great rest of the day, everybody. Thank you again, Abram.
Bye.
Hope to see everybody soon. Bye.